audience members, please do submit your questions, but I'll just take the moderator privilege and start diving in with one. I want to start locally with Shahed. I know we're so far, but going to start with you and your organization, Nora Health, which does a lot of work, including in India, to train family members to advocate more for their loved ones in hospitals and to provide better care when they're leaving the hospitals to return home together. So Shahed, Nora is already working across multiple countries and already recognized for its impact. At this stage in Nora Health's growth, what problem are you trying to solve, and what's the role of AI in your solution moving forward?
Thanks so much for having us and also for that question. At Nora Health, again, we support the family caregiver of the patient with the knowledge, skills, and confidence they need to care for their loved ones. We work with governments and health systems in order to incorporate these programs that really support caregivers. The anchor of our work really starts in healthcare facilities when families are anxiously waiting by their loved one, and we provide them a skill-based training by a trusted health worker in person to engage them in their loved one's care. Now, once they go home, families they'll face some sort of a challenge. They may need a reminder or a nudge to remember what to do in order to care for their loved ones. And so that's where, for us, technology and our mobile messaging service steps in. So after an in-person training, to continue to receive nudges and reminders for families once they go home. From the very beginning, as we've developed this service, we've not developed this as a chatbot because we wanted to always keep humans, that human connection between patients and families at home and a health worker at the back end as a critical and core part of what we do. But as we've scaled it, we have seen that whole process can become very constrained. We went from response times that were pretty quick to response times that needed to take more than 10 hours. So that's where AI really stepped in for us, to be able to address this challenge of keeping high quality support to families once they're at home, but also ensuring that response times don't balloon to something like 10 hours. We had families who loved the service. They would reach out to us and they would ask our nurses to name their newborn, but they were getting increasingly frustrated with how long it took. So we sat down with our health workers, and that's really where it begins, is to define what are the challenges that people are facing, and for us, those are health workers, and started to look at a lot of manual tasks that they were doing, looking up things in an FAQ database, annotating things manually, and then with them alongside us, we started to co-develop an AI co-pilot that supports health workers in answering questions, providing them context on the patient and family that they're supporting, and importantly, also tracking operational and other data so that we understand the quality of the responses in the system overall. And with that in place, we've been able to reduce those 10 hours down to 30 minutes. We've improved retention, so families, more than 30% of families keep coming back to us for more support. And importantly, the health workers are happier. They're getting to focus on what motivates them, which is to provide care versus to fill out a bunch of forms on an Excel sheet.
And to follow up on that, I've heard rumors, at least, that you're planning a randomized evaluation later this year on this. Could you say more about why you're exploring an RCT now, given that you already have some evidence of Nora's impact?
You are correct. For us, impact and evaluations is not a one-time thing. As we evolve, as the world changes, we need to continually update, the evidence that we have and the knowledge that we have. The RCT is really critical for us because while we've done evaluations on the model, some of the product metrics, how it's affecting users, ultimately what we hold ourselves accountable to is having an impact on health outcomes, things like newborn morbidity and mortality. And the RCT is a way for us to actually, in a more definitive way, answer that. So in a simple way, it is to understand the impact on this incredibly important outcome, which is newborn mortality, and to understand also incrementally what does the AI-supported tool provide versus our standard program, which is the in-person initiative. And hopefully with that data, ultimately what we want to do is to have family caregiver support be the standard of care across health systems globally. And what RCTs and this evidence that we're generating will allow us to do is to provide information on what works, what doesn't, to governments so that they can use their scarce resources in supporting caregivers most effectively.
Thank you so much. Zamir, I want to bring you in next and hear from you from the perspective of a funder who's thinking about technology diffusion a lot in health systems around the world. Because AI tools are evolving so rapidly, how should funders and implementers like Nora Health design evaluations that can keep pace with that reality while still producing evidence that's credible enough to drive adoption and policy?
Yeah, thanks, Amy. I must just depart for a second, and I wonder if Ziad is still around, because when Ziad made his admission about being a clinician that missed the diagnosis, I realized that's why I was invited to this panel. I too missed the diagnosis, and I was just remembering that it was actually my first trip to India 15 years ago. When I came here, had a great time, and went back home and had a classic swinging fever for 6 days and completely missed that it was typhoid fever, and 2 ended up in the surgery room with cholecystitis. So to Ziad, this is a bit of a clinician anonymous admission session. So thanks for creating a safe space. But Amy, to get to your question, and also, just to pick up on where Shahid left off, I think the role of evaluations for decision makers, for governments, where resources are scarce, is absolutely critical. And I can already tell from the proceedings this week that this will be one of the key messages we take back, which is we need to double down on evaluation, particularly giving decision makers the right kind of evidence at the right time. I'm a big fan of RCTs. They have fundamentally changed the global health landscape. But there are 2 kind of issues we need to grapple with. The one is the models change very fast. And I see some colleagues smiling with me because this is a very real issue. And I was doing a little bit of homework on how long does this take? It takes us 6 months to design the RCT. Let's do the RCT for maybe 24 months, and then take 18 months to publish the data. That means that if we all left here today and we started designing, Shahid, maybe 2029, we have some good results that you can put out there, right? I'm not saying that that's what we should do. The other reality is that policymakers, like in India, like in many countries we work in as the Gates Foundation, are really hoping that AI brings new promise, brings new tools to frontline workers that it's never been able to do before. And so the policy windows, the policy cycles don't track to publication cycles. Policy decisions are often made because of resource constraints, or there's an outbreak, or there's some political economy issue that drives a decision. And so being receptive to that means that we're going to have to challenge ourselves on conventional models of doing RCTs or long trial designs. That shouldn't mean that we compromise the evidence generation. So just to be clear, we have to have good evidence. But in the early phases, we can start thinking about, does this give us a safety signal? Can we do something in short step, in 3 to 6 months, that says, this looks like this could be safe, could be interesting, and very much to what the previous speaker said. Maybe those are short, inexpensive, quick experiments that we can run. Then we can move into kind of pragmatic trials, adaptive trial designs that don't take us 2 or 3 years, but give us the kind of evidence around adoption. And this is really key. We've seen lots of models perform really well in labs and desktops. They beat every single benchmark. And there's no doubt that most models today are better than clinicians. Those results don't hold up when you hit the field. Why? There's some fundamental issues. One trial we saw was that the clinicians actually didn't trust the AI. So adoptions was stuck at about 4, 5, 6% until someone actually sat with the clinicians, went through their own clinical cases and their mistakes, and showed them that somebody in the room, there were 100 clinicians in a trial in Kenya, and one of them was making the mistakes. And those mistakes were significant and catastrophic, that they then sat around the table and said, hang on, there's something we need to embrace about the technology. And then we saw adoption surge to upwards of 60%, still not at 100%. So I think that how we think about evidence is what's the right methodology for the right time. And again, want to just applaud, the Indian government and the India AI mission for proactively recognizing that evaluation and evidence will need to be a key part of the AI strategy for the country, setting up these centers of excellence on health, education, agriculture, etc. And then bringing really strong partners, like JPAL, who has the experience, but also locally like ICMR and many other folks who can kind of put our heads together, and I'm sure folks in the room, about what are the best ways to evaluate AI in a period where if we were stuck on one method that took us that long, we'd likely work ourselves into irrelevance and increase the inequality of how AI plays out.
Thank you so much for sharing that perspective, Zamir. Rob, I want to bring you in next. From a global governance vantage point, as we're thinking about what's needed to really drive adoption and policy and impact, what are the biggest privacy and governance mistakes that you see when health AI projects are scaling, and how can programs avoid them without stalling innovation?
So thanks for the question. I mean, I think it's really an exciting opportunity and an exciting moment where we are sitting here where the technology that is being built is capable of solving lots of different problems. We've heard about a bunch of them from this panel, from the speakers already, from preventing heart attacks to diagnosing anemia to giving personalized health guidance to people who otherwise wouldn't be served by the traditional healthcare system. So these are really exciting opportunities. And I before I answer the question about privacy and security, I want to say, I was just sitting here listening to this conversation and thinking back to the past couple of global AI summits that we've had. 4 years ago, the first one was in the UK. And I think I wouldn't have been able to say the same thing 4 years ago, that we build general purpose technology, like the kind of technology that my company builds, and then people use it for all of these compelling use cases that actually enable health delivery to scale and to enable the kind of health delivery that would have previously have been limited to more wealthy nations, to more limited populations, is something that everyone can have. And I just think that's a really exciting opportunity right now. So what are the big mistakes? The first one is just treating governance as a gate rather than a guide. I think very often you get into this mode where people say, hey, we're really worried about X issue. We're worried about privacy. I spent my career thinking about privacy. I worry about privacy a lot too. But I think it's important to realize that the fact that we are worried about privacy doesn't mean that we shouldn't be able to use data in novel ways in order to deliver really positive health outcomes. We actually did a study with Stanford University on something called deliberative democracy, basically looking at broadly representative groups of people in the US and in India and asking them for their attitudes about frontier AI. And one of the things that we found is here in India, 90+% of people said that they want AI to be used for cutting edge cures and that they're willing to contribute their data in privacy preserving ways to have that happen. And so I think as a starting point, it's important to know that if you're stopping the development or stopping the deployment because you're worried about those issues, rather than trying to build in a way that is privacy safe and that is secure, you're making a mistake. The other big thing, which I think we also heard, and I think you talked about earlier, is the idea of human in the loop. And the traditional understanding here is always humans are the gold standard. We should make sure that we have humans in the loop and making decisions at all times. And that has two consequences. You talked about mistakes, and you talked about people not getting access to care because there are bottlenecks. And so I've come to think about this problem, especially as we're getting to a point where the AI is potentially more capable than humans, faster than humans, and more reliable than humans. Thinking about humans as the architect, we should be driving the way that the technology should be used, and thinking about AI as a tool that can help us scale our impact so that we don't run into this case where people who could be helped by the technology aren't receiving it.
And Shahed or Zamir, do you have any reactions to Rob's comments here?
Yeah, it's Rob, you remind me of a real encounter I had speaking to a skeptic, head of neurosurgery at a very big hospital. I won't mention the name. He looked at me and he said, this AI thing is a complete waste of time. And it's not going to change anything in my practice. And, it was in South Africa. And he said, the only reason I'll give you 5 minutes is because you were my student at one point in time. And put me on the spot and said, there's the CT scan, now show me. And I was like, I didn't come and do a demo. I didn't have anything special in my pocket. I didn't have a trained model, and I took out the general purpose LLM, I won't say the name, took an image, it's multimodal, you know which one maybe. And I turned the phone around and he looked me dead in the eye and he said, hang on. Actually, this is crazy. Because he then told me the clinical case. This was a case, a very real case of a 12-year-old child who was admitted to a district hospital, who the clinician on duty was late in the morning, I don't know, looked at the child and said, child's got raised intracranial pressure of an unknown cause, and for whatever reason decided to do a lumbar puncture. Clinicians in the audience are gasping. You know what happened next. Unfortunately, the child comed. By the morning, the child did not survive. And when he looked at the LLM result, it said to him very clearly, it was the first time I saw bold and capital letters, do not lumbar puncture, whatever you do. That clinician turned around and said to me, this is something I've never seen before. And just last week, he emailed me to say he submitted his first publication to the New England Journal of Medicine on the power of AI for African communities. And that's where I think we're going to get to change, is when clinicians start to see the evidence and trust that this will make a change for their patients in a kind of real life situation.
Shahed, anything that you would briefly add in 30 seconds there? Okay. Before we get to one last question, I just want to say that this discussion has been really exciting for me personally, because while I can't say too much yet, JPAL is going to very soon be really massively expanding our work through a new initiative to support research on AI and health, specifically in low and middle income countries. And that's going to be formally announced on the 20th at the summit. So stay tuned for additional details there. But I just want to flag that with that new initiative in mind, we would be really eager to reconnect with the researchers and implementers and policymakers in the room here today, after the announcement on the 20th to speak more about how we can, build the evidence base on health and AI together and make those new evaluations possible. So with that in mind, as JPAL is looking to support even more research on AI and how to integrate promising tools into the health system, I want to hear from each of you one more time. So in 1 to 2 minutes each, based on your experience, what differentiates AI applications that succeed from those that fail? That could be data availability, regulation, evaluation, other factors. And what advice would you give to implementers who want to build AI into programs iteratively while also staying grounded and learning what works? So I'll start with Rob first, maybe, and then Shahed and Zamir, feel free to bounce off of that.
Sure. So I think that, I talked earlier about the downside risk of not deploying. And I think that, by thinking about things in binary terms, you often run into this case where you leave opportunity on the table. And I think the projects that are successful are ones that have a dual focus. They are thinking about the way to the upside. Who are they helping? What is the specific mechanism by which they're going to deliver that? They're thinking about governance up front. They're making sure that they're identifying the downside risks and they're building them in. So as an example, when we do our data modeling, we look at anonymization technology. So we take data and we build the data sets in ways that protect the anonymity of the people that are in it. So we don't have problems later on. And then thinking about access to data, this was something that came up earlier too, making sure that the data that's being used is broadly representative of the people that we're trying to serve. I think if you build a project and you build a model based on data from people in the US, you're going to end up with something that serves people in the US and doesn't serve people in the rest of the world. And so I think thinking about both a very clear targeted upside, a very clear mechanism of action, very clear governance for how to build it responsibly, and broadly representative data so that the technology and the models that you're building can serve as many people as possible. I think those are the key attributes.
Shahed, maybe over to you.
Sure, yeah, and thank you. Building on that, maybe would share like 3 things for implementers who are thinking about incorporating AI. First would be starting with people, not the technology. For us, that meant health workers understanding their needs, their challenges, their motivations as professionals deeply, and then seeing how this tool can unlock potential. Again, for us, that was about unlocking moments that they provide care. Second, it was really important for us to get very precise with our definitions. What do we even mean by good care? What's in the bounds of the service? What's out of the bounds of the service? Both of those things helped essentially provide a North Star for things like when we developed out the knowledge base, built in guardrails for our prompting. And again, do that in a way where we iteratively come back to it. And finally, especially because we had humans in the loop, putting that product or that tool out there to in a small geography for us to learn and understand and then iterate on. We learned so much more when we actually started to communicate with families and see what were the challenges that our health workers were facing when we put it out there. So again, of course, do that in a safe way. For us, it was keeping people in the loop, health workers specifically, and monitoring all the conversations. But what we learned was tremendous in those initial days.
Thanks, Amy. I think a couple of things. I mean, I think we're going to hear this week, lots about models and the cool tricks they're going to do and so on. I think it's a 10% problem. I think models, their accuracy will be 10% of what we need going forward. I think there's a 20% on how does this actually integrate? Like, what sort of infrastructure do you need? And then I think 70% of this is going to come down to change management and how we engage people and take people along on the journey. And I think if we neglect that, I think this is going to be an uphill battle for some time. I also think that as we think about evidence and adoption, there's a very real cost issue. You know, one of the studies we did in partnership with Path over here showed that the clinician assist consult actually only costs 4 US cents. And the accuracy was up to 97%. That may be expensive when you expand it over thousands, you know, of users, but actually the cost of compute will continue to come down. It's 240 times less than what it was 2.5 years ago. So you can easily start to see that this becomes scalable and sustainable. I think that one of the biggest game changers, if I was forced to bet, I don't bet, but if I was forced to bet on what I think could be the biggest game changer for development on AI, I think it's personalized health coaches in the pocket of every single individual that can speak in their language, that has context and memory over time, that eventually doesn't only serve health needs, but is your coach for education, is your coach for financial, but just a coach that you can trust with decision-making over time.
Thank you so much, Samir. That's a really exciting vision to lay out, and I think a good way to close. It was so great from hearing from each of you. I think this was just a great way to highlight the need for more evidence, the excitement around AI and health, and just really appreciate you taking the time to be here. And all of you for attending. Thank you.
Thank you so much to all of our AI and health speakers. It's really just amazing to hear their perspectives from every type of organization.